Welcome. Today we're examining material centered on a remarkable response in metastatic esophageal squamous cell carcinoma to a third-gen EGFR-TKI. And this analysis draws heavily from a very insightful review by Dr. Reza Lankarani, general surgeon, founder of the Surgical Pioneering newsletter and podcast series, and also editorial board member at the Genesis Journal of Surgery and Medicine. Essentially, the source looks at the first reported case of metastatic ESCC with this rare EGFR P768I mutation showing, well, an amazing response to a TKI.
Right, and it's a strong piece, no doubt. But for the intended audience, surgeons, tumor boards, we need to elevate it from just analysis to something more directive, a clear call to action. Let's jump right in with the first point. The methodology details. To really make the case for comprehensive genomic profiling being essential, the discussion has got to provide more detail on the specific molecular methods used. Now, the review does correctly flag that the original report was, let's say, light on specifics, things like the exact NGS platform.
Yeah, or TMB, PDL1 status, that kind of thing.
Exactly. Or even tracking resistance after the TKI started working. And look, for an audience that implements precision oncology, just pointing out the gap, it's not quite enough. It feels more like an observation than a clinical requirement.
Okay, but hold on. If it's a Silden case report, maybe an older one, isn't demanding all those fine details a bit much? Could that make it seem like an impossible standard, especially if they just didn't have that data back then? What's the practical gain versus the burden?
That's a fair question. The practical gain is confidence. It's the level of certainty we bring to the tumor board discussion. The weakness here isn't just identifying the gap, it's that the review doesn't use that gap to actively push for a higher standard. When you have such a dramatic finding, if you don't know the analytical limits, like what was the minimum detection level for that mutation on their NGS platform, it really weakens how generalizable the finding is. So the suggestion for improvement is this. Weave the need for these details directly into the clear clinical message part. Don't just list the missing bits. Frame them as essential criteria for any future biomarker-driven standard of care in this area. We need to set that bar.
Right, so shifting from here's what was missing to here's what must be included going forward. That makes sense. You mentioned ctDNA, circulating tumor DNA. Why is standardizing something like the variant allele frequency, the VAF, so critical for surgical follow-up, especially comparing across different centers?
That gets right to the heart of it. A concrete example here. Instead of vaguely saying it supports biomarker-driven care, we need to be more specific. Something like, this case supports biomarker-driven care, particularly using ctDNA for screening, provided that the analysis clearly states the parameters, like the minimum VAF detection limit or the type of NGS platform used. That detail makes the whole idea of precision follow-up feasible, concrete.
Okay.
Because if the surgeon is tracking minimal residual disease post-surgery using ctDNA, they absolutely need to know the threshold. What VAF percentage signals recurrence risk? If one lab says 0.1% is positive and another needs 1.0%, well, you don't have a standard, do you? It's apples and oranges.
Right. Consistency is key there. And what about the other missing data points you mentioned, TMB and PDL1? Those relate more to immunotherapy. In a case focused on a targeted TKI response, why are they still so important? Isn't that diluting the main point?
Not at all, actually. Because with ESCC, resistance is, well, almost inevitable down the line. Tracking those resistance mechanisms after the TTI response is crucial for long-term planning. Think about it. If the patient gets downstaged surgically or has a metastasectomy, great. But what happens when the TKI eventually stops working? We have to explicitly mention the need for TMB and PDL1 data because that information guides the next treatment choice. If the TKI fails, knowing the tumor's immune profile lets the team pivot quickly, maybe to a combo therapy, maybe a checkpoint inhibitor.
So it avoids treating a recurrence like a brand new unknown cancer.
Exactly. It turns what could be a short-term win into a potentially sustainable long-term management plan. That's the goal.
Okay, that makes sense.
Let's shift gears then, away from the lab specifics and more towards the immediate clinical impact, survival, operability. The data here is striking, but how do we make sure surgeons see it as directly relevant to their practice, not just an interesting medical oncology finding?
Yeah, that's the next critical point. While the material does a good job showing the interdisciplinary angle, it needs to connect that amazing therapeutic response much more forcefully to the practical surgical questions, operability, and long-term strategies.
The review mentions the potential for downstaging, which is great, but then immediately points out the lack of surgical data in the original report. Doesn't that create a kind of disconnect? Surgeons might think, okay, the drug worked, but did it actually change the surgery or the outcome? How do we avoid that?
That is the disconnect we need to bridge. You're spot on. For a surgeon focused on esophageal resections, hearing about a great drug response is exciting, but if they don't know if it led to an easier R0 resection or a better path response, the excitement fades fast. So the suggestion here is to really leverage that headline number, the reported 80% objective response rate for this ESCC S768I mutation, and use the expert opinion idea about turning incurable cases into chronic manageable ones. Frame the specific case response as a potential game changer for things like metastasectomy or neoadjuvant approaches. Make it sound revolutionary, because potentially it is.
And we really need to emphasize how unusual that 80% response rate is compared to historical treatments for ESCC. That contrast is key, right?
Absolutely crucial. That numerical difference is the motivator. Here's a concrete example of how to phrase it. When discussing the impact, don't just say, good response, spell it out. Contrast the 80% objective response rate for S768I positive ESCC with the historical, 5% ORR you'd expect for unselected ESCC getting standard chemo.
Wow, yeah, 80 versus 5%.
It's a massive difference, 16 times better. That's the context needed to really shift a surgeon's thinking from automatic palliative intent towards considering metastasectomy or pushing for curative margins in cases previously thought unresectable.
And the limitation, the no surgical data part, we shouldn't present that as just a flaw in the original paper. It needs to be a springboard for action for the audience reading this review.
Precisely. Frame that limitation as an immediate call to arms. It should lead directly to advocating for new clinical trials. Specifically, things like basket trials looking at EGFR targets across different cancers, including ESCC. And these trials must explicitly link that systemic molecular response, that 80% ORR, directly to surgical metrics, R0 resection rates, pathological complete response rates, even complication rates. Tie the drug success directly to better surgical possibilities.
Got it. Frame the medical success as enabling better surgery. Okay, so we've covered methodological rigor and surgical potential. Let's talk about the final piece, education. This review aims to teach the whole team. How do we make sure the core educational message, the significance of this rare finding, hits home right from the start?
Good question. To really maximize the educational takeaway, the material needs to draw a clearer line right up front between the common view of ESCC as TKI insensitive and the, frankly, transformative effect seen with this rare specific mutation.
I noticed the patient-friendly summary does a decent job explaining the impact for lay readers, but in the main text, the overview of content section, it doesn't really emphasize the rarity strongly enough at the beginning. Someone might just skim it and think, oh, another oncology update, missing the key point.
Which is
that a variant usually seen in lung cancer worked dramatically in a GI cancer type, typically considered non-responsive. That's the news here.
Exactly. That's the weakness. The main educational point that ESCC isn't monolithic, it's molecularly diverse, kind of lands too late. It should be the headline. So the suggestion is straightforward. Introduce the significance of testing for these non-classical variants immediately. Make sure those specific mutation names, P.S768I, G719X, L861Q, are mentioned early and clearly. Drive home why current testing protocols might need updating.
But is it practical to push for including these really specific low-frequency variants like S768I, G719X, L861Q in routine NGS panels? Won't that impact turnaround time, cost, especially for busy labs dealing mostly with negative results for these rare ones?
That's the unavoidable trade-off, isn't it? But the argument has to be that the potential benefit achieving such a dramatic, potentially life-extending response vastly outweighs that marginal cost increase or slight delay. The whole point of an educational review like this is to help define a new, better standard of care. So, a concrete example. In the opening overview, state explicitly that the significance here is how this case challenges the old notion of ESCC non-responsiveness by highlighting a rare variant typically linked to lung cancer.
Use that shock value right away.
Yes, hit them with the paradigm shift up front. That justifies the deep dive that follows.
Okay, so make the challenge to dogma the opening statement, not just a concluding thought. And give the clinicians the specific molecular language they need, those variant MAMEs, so they can actually push for change in their own institutions.
Precisely. It needs to be actionable. For instance, in the Impact and Significance section, that goal supports inclusion of EGFR non-classical variants like S768I, G719X, L861Q in ESCC NGS panels shouldn't just be a sentence. Make it a bold header. Make it unavoidable. That formatting, that directness, forces tumor boards to confront which specific variants they now need to consider. It makes the clinical need immediate, cutting through any historical assumptions about ESCC.
Right. This has been incredibly useful. Really focus on taking what's already a very strong review and making it even more impactful, more prescriptive for that surgical and oncology audience.
Yeah, the goal was always maximizing utility, making every suggestion actionable, pushing beyond just observing the limitations of the original case report itself.
Okay, so to quickly recap the 3 core areas for improvement for our listener. First, enhance the methodological specificity. Define required NGS parameters like VAF to really solidify the call for standardized biomarker-driven care.
Second, sharpen that surgical angle. Use the striking 80% response rate to frame this as potential for curative surgery or downstaging, and explicitly link future trials to surgical outcomes like R0 rates.
And third, boost the educational clarity. Emphasize the rarity and significance of those specific non-classical EGFR variants, P.S768I, G719X, L861Q right from the beginning, to accelerate changes in testing protocols.
Exactly. Implement those strategic changes, and the review's influence and prescriptive power will increase significantly.
Fantastic. And just a reminder, this critique was based on the profound review by Dr. Reza Lankarani, who serves on the editorial board of the Genesis Journal of Surgery and Medicine. For anyone wanting more details or context from Dr. Lankarani's work, including the Surgical Pioneering podcast series, you can find the application at surgicalpioneer.codax.me. We look forward to reviewing the revised